protein would definitely have more than 3 amino acids, okay? But we're not gonna sit here and make a protein with 100 amino acids, okay? We'll put 3 together and that'll give you an idea of what's going on. Okay. So I'm gonna put an amino acid here. There's 1 amino acid at neutral pH. And I'm going to put another one here. That one there. Let me just double check one thing before I do all this. One thing. Just had to do a quick review of this peptide bond. Okay. And then, okay, so let's link these 2 together first. Okay. When you go to link 2 amino acids together, what you're always going to do is you're going to take the carboxyl of 1 amino acid and link it to the amino group of another amino acid. Okay, so it's always carboxyl 1, amino of the other. So whenever you're doing these reactions where you're taking building blocks and making something bigger out of them, those are called dehydration reactions. And you don't need to know that for this test. At some point you should have learned it in bio, but regardless. And when you do these dehydration reactions, you always yield a molecule of water when you link 2 things together. Okay? So what we're gonna do to link these together, that would require an enzyme, which we're not gonna worry about, but we have to release a molecule of water in the process. And what's gonna get released as the water is gonna be H2O, okay? Those things are gonna come off and form water. And when these guys come off, the rest of this, what's left of that carboxyl group, and what's left of the amino group come together to form a peptide bond. So that would look like this. We would have NH3, this, central carbon, hydrogen, variable R group. And then here we would have that carbon, double bound to that oxygen. That oxygen's going away. These 2 hydrogens are going away. And we're gonna have nitrogen with a hydrogen sticking off of it. Oops. Keep that in green. Nitrogen with a hydrogen coming off of it. Central carbon, hydrogen, R group, carboxyl. And this bond right here, that bond right there, where we link these 2 amino acids together, that's a peptide bond. And in the process of making that bond, we released water, okay? And again, that water is HHO. Okay? That's our water right there. And as you build an amino acid, you just keep doing that. You just keep adding a new amino group and forming a peptide bond, okay? So let's do one more. Stick 1 more amino acid on there. Let's do that one in red. So again, it's gonna be the carboxyl group of 1 amino acid is going to interact with the amino group of our next amino acid. So right here, these guys are gonna come together and form a peptide bond. Again, we've got to release a molecule of water, so that oxygen right here is gonna go away. 2 of those hydrogens are gonna go away. And we're gonna put a peptide bond right there. Okay, so there's our peptide bond. Okay, so there's the carbon double bound to oxygen, carbon double bond to oxygen. I just wrote it as CO, but I could do that, okay? That makes it clear. Here you've got your nitrogen with a hydrogen, nitrogen with a hydrogen. If it makes it easier, you can do that. And again, when we form that bond, we have to release water. And that water came from the oxygen here and 2 hydrogens here. There's our water that's released. So as we start building this protein, we just, again, keep doing that, keep doing that, keep doing that, keep doing that. And then if we think about this protein being a buffer, it really doesn't buffer much better than a single amino acid. Because when we look at the protein, what's gonna act as the weak acid is gonna be the amino group, just like it was on our amino acid. So we have to come all the way down to one end of this protein. So right here, that part of this protein, the very end of it, acts as the weak acid. So that will be our weak acid. That can release hydrogens to the solution. And that would occur if the pH was too high. If pH was too high and we needed to bring the pH down, it would be this part of the molecule, the amino group, at one end of the molecule that could release hydrogen ions. If we look here, this right here, this nitrogen is no longer an amino group and it's bound up in a peptide bond, so we can't do anything anymore. This nitrogen that used to be part of an amino group is no longer an amino group anymore. It can't do anything because it's bound up in a peptide bond. So just like a single amino acid, there's just one amino group on a protein that can act as the weak acid. It's the one at the whole end, at the far end of the molecule. If our pH were if our pH was too low, and we needed a protein to temporarily fix it, then it would be the carboxyl group that would absorb hydrogens, just like our amino acid. And again, if we look at this protein, the only place that we have a carboxyl group to absorb an amino acid is at the other end of the molecule, here. Here, this is no longer a carboxyl group. It can't absorb hydrogens because it's bound up in a peptide bond. Here, what used to be a carboxyl is no longer a carboxyl, and it's bound up in a peptide bond, so we can't do anything anymore. So again, it's going to be the ends of the molecule, just like ends of the amino acid will be your buffering areas. So this carboxyl group, if the pH is too low, it'll be this carboxyl that can absorb hydrogens from the solution. When the pH of the solution is too low and this carboxyl group is acting as a weak base, just like we saw with the amino acid. The only difference that a protein can do for us that an amino acid couldn't do is this. Sometimes, depending on what the R group is, depending on what that R group is, sometimes it can act as a weak base and absorb hydrogens like the carboxyl group can. It depends on what that R group is. If that R group were just a hydrogen, it couldn't do that. But if this R group had an oxygen with a negative charge to it, like the carboxyl did, then it could absorb hydrogen ions. And if we have a protein, then it has more potential R groups to potentially act also as a weak base. The problem with protein is that these R groups tend to be involved in the folding of the protein. So they're not just sitting out there waiting to act as a weak base. So again, the point is that proteins really aren't much better at buffers as a single amino acid is, okay? We're not gonna worry about R groups. We're not gonna worry about which R groups can buffer, which ones can't. So I just wanted you to realize that was a potential option, but I'm not gonna ask you anything about that. What I want you to know is the carboxyl end, what a carboxyl end is, and that this carboxyl end can act as a weak base by absorbing. The amino end, I want you to know what an amino group looks like, and that that can act as a weak acid and release. Okay, questions on that? Okay. So then, let's say a real quick word about hemoglobin, okay? Now, what we have learned is, if you look at your systemic capillaries, okay? Let's get rid of some of this stuff and draw this up. Okay, erase. Okay, this is what we have learned so far. We said that if you've got cells out in your body, you've got cells, your cells are using oxygen to make ATP. And as these cells are using oxygen to make ATP, they are producing and releasing CO2, okay? And if you look at your systemic capillaries, as this oxygen-rich blood, it's an O2-rich, CO poor, as that comes into your systemic capillaries, oxygen's gonna diffuse this direction out to your cells, and CO2 is gonna diffuse this way into your blood, okay? And that happens at your systemic capillaries. So that as blood leaves your systemic capillaries and heads back to your heart, this blood would be O2 poor and CO2 rich. All right, so if that's what's happening, we said when that CO2 enters your blood, okay, when CO2 enters your systemic capillaries, we said that about 7% just will dissolve right in the plasma of your blood as CO2. Okay. We said that the rest of it, 93%, will diffuse into your red blood cells. And of that 93% of your CO2 that diffused into a red blood cell, 23% would bind to hemoglobin in your red blood cells. Okay? And it would bind to the protein part of hemoglobin. So we learned that when we did respiratory system, okay? And then we said the rest of it, 70%, is gonna do this. 70% of the CO2 that entered into your bloodstream at your systemic capillaries that is now inside of your red blood cells is gonna interact with water in your red blood cells. In your red blood cells, you have an enzyme called carbonic anhydrase. And that enzyme is going to help facilitate the formation of carbonic acid. We've said carbonic acid is really unstable, very unstable. It won't stay as carbonic acid. We've said it will either go back and form CO2 and water, or it will further break apart into hydrogen ions and bicarbonate ions. Okay. And we said that this is how, as CO2 levels rise, you end up with more free hydrogen ions and your pH drops. Okay, so what we said. And then we just left it at this, okay? But now we need to come back and think about this. Because if the majority of your CO2, when it enters into your bloodstream, does this, then that means really fast, you're gonna end up with a whole bunch of free hydrogen ions in that blood that's in your systemic capillaries, just like that. And if these hydrogen ions were just freely floating around in your bloodstream, your pH would plummet, and then you would be dead. So that means you can't just let this just sit like that in your bloodstream. It's gotta be buffered immediately. Fortunately, in our blood, we have, in our red blood cells, which is where we have hemoglobin. So these hydrogen ions that are immediately released when CO2 enters the red blood cell and does this chemical reaction, these hydrogens get buffered by hemoglobin so that our pH doesn't plummet. But then we need to look at this. What happens to our bicarbonate? Remember when we talked last time, I said that you've got a lot of bicarbonate extracellularly, and that was going to be really important today, and we would see why it's so important. But at this point, we're looking at bicarbonate, and we get a lot of bicarbonate released through this pathway. Right now, we're inside of a red blood cell, okay? And we need a lot of bicarb outside of cells. We've seen how we can get a lot of bicarb extracellularly at the DCT, and we'll review that again later. But how do we get a lot of bicarb extracellularly through this pathway? What happens to this bicarb here is, if you look at a red blood cell, and we've got CO2 entering that red blood cell, interacting with water, forming carbonic acid, breaking down into hydrogen and bicarbonate ions. And we said these hydrogens get buffered by hemoglobin that's in that red blood cell. Then what's going to happen to that bicarb is that bicarb is transported out of the cell. As that bicarb is transported out of the cell, we also are going to transport something into the cell, and that something is chloride. Okay? So the way we get that bicarb out of the red blood cells is through a transporter that moves bicarb one direction and chloride the other direction. And that is called your chloride shift right here. That's called a chloride shift. You exchange the bicarb that's produced with chloride. So if you were to look at your venous blood, okay, if you were to look at your venous blood here in the systemic circuit, you've got a lot of CO2, okay, and what you would see is that in the plasma, you would have a little bit less chloride because it got pumped into your red blood cells, and your bicarbonate would be a little bit higher because it got pumped out. Okay? So if you look at your venous blood in the systemic circuit, you would see that you would have a bit more bicarb in the plasma and a bit less chloride in the plasma because of this chloride shift right there that happens. At your pulmonary capillaries, we saw all this reaction go in reverse. And at your pulmonary capillaries, not only does this reaction go in reverse, so that at the pulmonary capillaries, we end up producing CO2 and water that will diffuse into the alveoli to be exhaled. We have to then think about, wait a second, that bicarb is not inside of the red blood cell anymore. That bicarb we pumped out. So at the pulmonary capillaries, you see this go in reverse. You see that bicarb gets pumped into the red blood cell as chloride gets pumped out. You see the exact opposite happen here. And once you have that bicarb in your red blood cell, your hemoglobin will start releasing the hydrogens. Hydrogens are released by the hemoglobin. And then you can get those two things coming together. Hydrogens by carbs come together to form carbonic acid in the red blood cells at the pulmonary capillaries. That then forms CO2 and water. That diffuses out of your red blood cells into the alveoli so that it can be exhaled. So in your pulmonary capillaries, you would see these numbers be flipped. Okay? You would see them be flipped. At your pulmonary capillaries, you would see that these numbers would be opposite because they're being transported in the opposite direction. Okay, that's called a chloride shift. All right, so we've got two more buffer systems to talk about. Okay, I'm gonna set questions on this before I erase this and we do our second buffer system. And I'm actually gonna skip over this one. We're gonna do this one, but I wanna do this one last. We're gonna do this one second. Okay, and then I'll come back to that one. All right, let me erase this stuff. All right, the next one that we're going to talk about is your major intracellular buffer system. And on this, the formatting is a little bit weird, so we're going to rewrite that equation and clean up some of that formatting that's confusing. Okay? So again, we're following this right here. Okay? When we look inside of our cells, okay, what we're going to see inside of our cells is a lot of disodium monohydrogen phosphate. Okay, let me say it again. Disodium, two sodiums, monohydrogen, one hydrogen phosphate. You just have a lot of that in your cells. Now remember, you still have more sodium outside of your cells than you do in, by far. But you do have a lot of that disodium monohydrogen phosphate in your cells, you just do. And so what that can do is, I'm gonna write it up here. If you look at that molecule inside of your cells, it will disassociate, it'll break apart, right? And when it breaks apart, so this is inside the cells, it will break apart into two sodiums plus monohydrogen phosphate. That's what, 2 minus, is that 2 minus? Yeah, 2 minus, okay? That reaction is just always happening in your cells, okay? Two sodiums and monohydrogen phosphate can come together to form disodium monohydrogen phosphate. Okay? Or, when this molecule, disodium monohydrogen phosphate, when it disassociates, these sodiums can go do something else. They can go interact with, for example, chloride and form salt, or whatever. They can go do other things, okay? And so can this molecule. It can go do other reactions. Okay. The point is, we just have a lot of that in our cells. And we have mentioned before, that if you look inside of cells, you've got a lot of potassium inside of your cells. We said you've got a lot of negatively charged proteins in your cells. We said you've got a lot of magnesium in your cells. And we said you've got a lot of monohydrogen phosphate inside of your cells. You just do. You have a lot of that in there. And so what this monohydrogen phosphate can do is it can act as a buffering system. So what this thing can do, monohydrogen phosphate, can act as a weak base. Okay, can act as a weak base. And if it acts as a weak base, it will start absorbing what? What do weak bases absorb? Hydrogens. Okay, so it could start absorbing hydrogens. And when monohydrogen phosphate, I'm going to write this down here. and then I'll explain why the formatting's weird over there. Monohydrogen phosphate. When it absorbs hydrogens, it then forms dihydrogen phosphate. Yeah. So this is dihydrogen phosphate. And dihydrogen phosphate can act as a weak acid. And if it acts as a weak acid, it can then release hydrogen ions, and then you get an anion as well. So again, we're just following that basic equation up there. I'm gonna write this. Our dihydrogen phosphate would be our HY, acts as a weak acid, can release hydrogen ions plus the anion. In this case, the anion is monohydrogen phosphate, which can act as a weak base, absorbing hydrogens to form this, our weak acid. So that's just our equation right there. Now over here, why the formatting is a little bit weird. Okay, so here we've got dihydrogen phosphate, releases hydrogens, and our anion, monohydrogen phosphate. Oh, I fixed it. Okay, never mind. It used to be weird, I fixed it. Okay, so if I said this, if I said your intracellular pH starts to drop, okay, to temporarily fix, you would see dot, and I'm going to give you some choices, okay? You would see your buffer act more as a weak what? And then we're going to say you would see more or less dihydrogen phosphate, more or less free hydrogen ions, more or less monohydrogen phosphate. Okay. So if your intracellular pH started to drop, you would say that means I have too many or too few free hydrogens inside of my cell. Too many, okay? Too many free hydrogens in the cell. So do I want this buffering system, that is my major intracellular buffering system, do I want it acting more as a weak acid or more as a weak base to fix this problem? If it's a weak acid, it will release more hydrogens, making the pH go even lower. So I would want this buffering system to act more as a weak base. Weak base is going to absorb hydrogens. So what I would see is this reaction would shift more to the left. Okay, more to the left. Not completely, just shift a little bit more. And as it started doing this a little bit more, would I end up with more or less free hydrogens in that solution? Less, because that's the whole point of this, is to have less. And as I have less of those, my pH will come back up to range. Okay. And the way I have less of these is because this weak base is absorbing those hydrogens. So would I end up with more or less of this freely floating around in my intracellular fluids? Less. And as I have each of these less, that means I must have their combined effect must end up being more, okay? And that's always how I walk my way through these questions, always, okay? Okay, opposite pH, you would just do the opposite thing, okay? Questions on that one? All right, good. All right, so now we're gonna backtrack and we're gonna talk about this carbonic acid bicarbonate buffering system. the first thing we're gonna do is say when you can't use this system, okay? And then we're gonna write it out and do the same thing that we've been doing here, okay? So, the carbonic acid bicarbonate buffering system is your major extracellular buffering system. You cannot use this, actually let me say this first. When you will use this is gonna be primarily if you're trying to temporarily buffer your pH because you have a lot of organic acids and or a lot of fixed acids in your solution. Okay. This system, we cannot use it. Let me come back to this. Okay, let me make sure that we know like what an organic acid is. An organic acid would be something like lactic acid that you produce anaerobically. Ketones that you would produce if you have uncontrolled diabetes mellitus, or if you haven't eaten in a long time and you're having to break down your adipose tissue, right? You produce ketones as a byproduct. Those would be organic acids. Fixed acids would be things that you'd break down, that you would get from like breaking down amino acids, breaking down phospholipids, your plasma membranes. What I want you to notice up here is it doesn't say anything about volatile acids, okay? You cannot use this system if you're dealing with volatile acids. You'll see what that means in just a minute. Okay, so you can't use this system if you are dealing with respiratory acidosis or respiratory alkalosis. You can't use this to buffer. So when is that? Remember, respiratory acidosis is when your pH becomes too low because your CO2 levels are too high. You can't use this to buffer that problem. You can't use this if you have respiratory alkalosis. Your pH is too high because your CO2 levels are too low. You basically cannot use this as a buffering system if the reason your pH is too high or too low has anything to do with CO2 levels. You can't use this as your buffering system. Okay, and you'll see why in just a minute. You also cannot use this as your buffering system if your respiratory system is severely compromised and or you can't trigger a respiratory reflex. If you can't change your respiratory rate easily, you can't use this as a buffering system. So that means if you have some kind of spinal cord injury and you can't get information to your brainstem, you'd probably be dead anyway, but you definitely couldn't use this as a buffering system. Okay? Lastly, you can't use this as a buffering system if, let's see, how do I want to say this? If you don't have enough bicarbonate in your extracellular fluids. Okay, that rarely happens. Okay, that rarely happens. We'll talk more about this later, but why you might have too little bicarb is if you're dealing with diarrhea. Okay, and let me just give you kind of a scenario of what's going on there. If you have diarrhea, what's happening, and if you've done your GI worksheet, you've seen this already, but if you have diarrhea, your food, your liquid form of your food is moving through your GI tract too fast, okay? And when that material, it's called chyme when it's in its liquid form, when it gets to your colon, your large intestine, if it's moving through there too fast, it doesn't allow enough time for water to get reabsorbed, okay? And that's how you end up with diarrhea. It's very watery because you're not allowing enough time for the water to get into your body. What can also happen if you have diarrhea is your bicarb that's in your foods and liquids that you consume doesn't get absorbed. If you have chronic diarrhea, this is not just like, oh, I've got a little stomach thing and I have diarrhea like one day. This is like a chronic thing. So irritable bowel syndrome, this can be a problem. If you have chronic diarrhea, then the problem is that everything moves through the GI tract so fast that you tend to not absorb enough of it, and it just ends up in the toilet, basically, not in your bloodstream. And one of those things that won't get absorbed, not only water, but bicarbonate ions. So that rarely is an issue. Usually you've got plenty of bicarbs, and we've seen two ways to make sure you have plenty of bicarbs. One is a DCT, you tend to secrete hydrogens and reabsorb bicarbs. We saw at the red blood cells, you tend to transport bicarb out and chloride in, and you tend to get plenty of bicarb in your foods and liquids that you consume through your GI tract. So running out, and plus there's other ways to make bicarb too that we're not going to talk about. Usually don't have a problem with this, but if you did, you couldn't use this as your buffering system, okay? Now, again, this rarely happens. This rarely happens. Usually you can trigger respiratory reflex. Usually your brainstem isn't damaged, okay? So this rarely happens, but it could happen. This potentially is problematic, okay? But those situations, you cannot use this as your buffering system. So let's say that we're not dealing with those things. Let's say that we are doing some really strenuous muscular activity. We're doing a lot of anaerobic metabolism, and we're producing a lot of lactic acid. Let's say that's what we're doing. And in that situation, we can use this as a buffering system. So let's look and see how it would work. Now, this buffering system uses that same equation that we've seen multiple times now. We've seen this equation, CO2 and water forms carbonic acid, breaks down into hydrogen and bicarb. We've seen that equation to talk about how CO2 and pH are related to one another. We've used this equation to see how most of the CO2 travels in the bloodstream at your systemic capillaries and throughout your bloodstream. And now we're going to see that that equation is actually used as a buffering system, because not just red blood cells have carbonic anhydrase. Many cells have carbonic anhydrase. And anyway, this would be found outside of cells anyway, not inside of cells. But we've got carbonic anhydrase lots of places. So the way this system works is, outside of your cells, you have a lot of sodium bicarb. Okay, we've already said that you've got a lot of sodium outside of cells. You've got a lot of bicarb outside of cells. So we've got what's called a sodium bicarb reserve. This is called a sodium bicarbonate reserve, and you just have a lot of that. So this can break down into sodium and bicarb. And then sodium bicarb could come back together to form sodium bicarb or not. Sodium can go on to do other things. Bicarb can go on to do other things. Okay. What the bicarb can do, bicarb can act as a weak base. It can act as a weak base, and it can absorb hydrogen ions. So let's say we're producing a lot of lactic acid, and let's say that we've got a whole bunch of lactic acid floating around, and it's causing our pH to drop. Strenuous muscular activities. So to temporarily fix that problem, right? So this, all that lactic acid is making our extracellular fluid pH to drop. So then to temporarily fix, we could see bicarb that we have a lot of extracellularly. It can start buffering these hydrogen ions. It can start absorbing those hydrogens. And when it does that, we can get that, right? So there's our buffered hydrogen. there's our bicarb, HCO3. You put that together, what do you got? H2CO3, carbonic acid. Now, we're not going to be able to stop here, okay? But before I go any further in this direction, let me just say that carbonic acid can also act as a weak acid, right? Carbonic acid could release a hydrogen ion, and you would then have the anion being released as well. So carbonic acid can act as a weak acid by releasing hydrogens, and then you would have your anion. In our situation here, it's definitely not going to act as a weak acid because we have way too many hydrogens. In our example, this buffering system is going to act as a weak base and absorb these hydrogens and drive this reaction to the left. Now, since carbonic acid is so unstable, we know that it can either go back and form that, or it can further go this way. And if we have all these hydrogens floating around, because our pH is dropping, we already know we've got a lot of bicarb extracellularly. So if we've got tons of these two things, the reaction is definitely not going to go this way, because all that would do is make our pH even worse by releasing hydrogens. So if we've got all these hydrogens, because pH is low, and we already have lots of bicarb, it's going to drive the reaction that way. And so what we're going to get is carbonic acid is going to break down, like we already know, into CO2 and water. And as long as this starts to build up, as long as we can trigger a respiratory reflex to increase our respiratory rate and exhale this is a great buffering system. Okay? This is not a great buffering system if we can't trigger a respiratory reflex. If we can't trigger a respiratory reflex as CO2 levels start to rise, then what's going to happen? If CO2 levels rise and we can't increase our respiratory rate, it's going to drive the reaction back that way. And if all this CO2 is building up and we can't increase our respiratory rate and drives the reaction this way, we're going to end up with tons of hydrogen ions. And again, we're back where we started. The pH is going to drop. So that's why we cannot use this as a buffering system if we can't get rid of the CO2 and water that we produce from this system. Okay? So again, this is why we can't use this as a buffering system if we have respiratory acidosis. If we have respiratory acidosis, the whole problem is that CO2 is rising because we are hypoventilating. And if we're hypoventilating, we can't fix this problem, at least initially, and it's driving everything like this, and our pH drops. So if that's what's going on, you can't use this as a buffering system, okay? Again, because your underlying problem is you can't breathe fast enough. But if your respiratory system works fine, if you can trigger a respiratory reflex, then this is a good system. We've got plenty of this. It can absorb these. You form carbonic acid, it breaks down immediately into CO2 and water. You trigger a respiratory reflex and you get rid of this. And your pH comes back up to homeostatic range. Questions on that? Now, you could use this if your pH is too high. It doesn't happen very often, but it could happen. So let's just look at that for a second. If your pH were too high, let's get rid of this stuff. No, we won't even go through it. Really, this is a buffering system to be used for having too much organic or fixed acids. We're just going to leave it at that. Okay, questions on that thing? All right, so now we are ready to look at acid-base disorders. Is that felt right? Yeah. Good. Okay. All right, so when we look at acid-base balance, okay, again, our buffers are a temporary fix. To get rid of hydrogen ions, we've got two ways to do it, and we really need both of these ways working together. We can either, or we're gonna do both, but talking about them individually, we can change our respiratory rate, and by changing our respiratory rate, we can alter our CO2 levels. And by altering our CO2 levels, we can alter our pH. Okay? So for example, if, let's say it like this, if our blood pH was too low, okay, that means that we have too many free hydrogens floating around. And one way that we could try to fix this is we could trigger a respiratory reflex and increase our respiratory rate. And as we increase our respiratory rate, what do we see happening at the lungs? We'll see this happen. At the pulmonary capillaries, you would see hydrogen ions in the blood interacting with bicarbonate ions in the blood. That would form carbonic acid in the blood at the pulmonary capillaries. That would break down into CO2 and water. The CO2 and water that forms in the blood at the pulmonary capillaries would diffuse out and diffuse into the alveoli. And then that would be exhaled. So if our respiratory rate's high, we're exhaling a lot. And if we're exhaling a lot, that means we're getting rid of a lot of these. And if we're exhaling a lot and we're getting rid of a lot of these, then our pH will come back up to range. That's a homeostatic correction right there. We're literally getting rid of them, okay? We're not just binding them up on a buffer. We are literally getting them out of the body, okay? They leave the body as hydrogens in the water. That's how they leave the body. These hydrogen ions are here, and then they're here in the water, and the water is getting exhaled. We also, at the DCT, we can secrete hydrogen ions if we have too many of them. We do the opposite to bicarb. So we secrete hydrogens, we reabsorb bicarb. We literally are getting rid of hydrogens while we put the bicarb back into our blood, and that helps to keep our sodium bicarb reserve nice and high. Having this stay nice and high is good because it works as a buffering system. All right, so what we're going to do is look at these 4 acid-base disorders. We're going to say what causes these 4 acid-base disorders and how does the body try to fix them. Okay? 2 of these we already know. We're going to review them, but we already know 2 of them. We know respiratory acidosis and respiratory alkalosis. We're going to review those, and we're going to add 2 more onto the mix, and that's metabolic acidosis, metabolic alkalosis. And again, as you're listening to this, if you're finding that, oh, I kind of get it, but not really, or you just feel like, I'm just totally confused, do that worksheet, okay? That worksheet that's posted under study guides walks you through each one of these, okay? It walks you through what buffers to use. Does your buffer act as a weak acid, a weak base temporarily fixed, and then it walks you through your respiratory activities and your DCT activities to try to homeostatically correct, and it'll walk you through with all this stuff. Okay? All right, so let's go through it. So we're going to start with the respiratory stuff that we already know, and then we'll add on the metabolic stuff. all four of these in the formula, okay? You need to know these. These are big deals, especially if you're working in the ER. You better know how to treat this stuff. Okay? These things can be life-threatening really fast, okay? So they are big, big deals. Okay. Respiratory acid, let's get rid of this because don't leave that up anymore. Okay, respiratory acidosis. Okay, obviously this is when your pH becomes too low. Okay, so let's put normal pH up here because I'm going to want you to know that. 7.35 to 7.45 is your normal blood pH. So respiratory acidosis is when your blood pH becomes too low, which means less than 7.35. Okay, and again, I want you to know all this stuff. So less than 7.35 because, okay, and the cause and effect is critical for these things. Because, or due to, the partial pressure of CO2 becoming too high. And then your partial pressure of CO2, I think that's 45. I think it's 45. It's on the worksheet. I think it's 45. Is it 45? Yeah, yes, good. Okay, and that's 45 millimeters of mercury. Okay, so then you say, what caused your CO2 levels to become so high? The overall problem, so the underlying problem, is anything that causes the individual to hypoventilate. Anything that makes the individual hypoventilate is going to cause the CO2 levels to rise. And as the CO2 levels rise, that means that this person will have more free hydrogen ions floating around and their pH drops. Okay? And again, the reason that happens is because of this equation. Because 70% of all of your CO2 does this when it enters the bloodstream. You got all these hydrogens. Now, yes, some of them, many of them will get buffered by hemoglobin. But if you've got a lot of CO2, now you're producing a whole bunch of those, okay? And your pH starts to drop. All right, so how do we try to fix this? Okay, we're gonna fix it a few ways are gonna kick in. So first of all, let's make sure we know how to read these. Okay, so let's see, where are we gonna start? Okay, so we're in homeostasis. Individual starts to hypoventilate. Hypoventilation causes a rise in the partial pressure of CO2. CO2 being too high causes a drop in the blood pH. And now we're in respiratory acidosis at that point. Respiratory acidosis then is going to try to be corrected. First of all, first thing that's going to try to kick in are buffering systems. Are going to try to fix this right away. Buffer systems are going to buffering systems will act as weak bases to absorb hydrogen ions, except we can't use the carbonic acid bicarbonate buffering system. We can't use that buffering system if the reason our pH is too high or too low is because of CO2 levels or because of bicarbonate levels. We can't use this as a buffering system. Bicarbonate, carbonic acid, bicarbonate buffering system. You can't use this as your buffering system if the reason your pH is too high or too low has to do with too many or too few bicarbs or too many or too few CO2 levels. Okay, you can't use this as a buffering system if the reason you're in that situation is because of this being too high or too low, or that being too high or too low. So in respiratory acidosis, this buffering system cannot help us, but the others will. Proteins, amino acids, if we've got intracellular things going on, all those other buffering systems, plus other ones we didn't talk about, we'll try to fix this problem temporarily by acting more as weak bases and absorbing these hydrogen ions. Then to homeostatically try to correct this, we're gonna see at the DCT, hydrogen ions will be secreted at the DCT, and bicarbonate ions, I want you to cross out generated and put reabsorbed. Now, bicarb also does get generated in the filtrate, okay? But we didn't talk about that pathway, okay? So though yes, it does get generated, we didn't talk about that. What we did talk about was whatever you do to hydrogen at the DCT, you do the opposite to bicarb, right? So, hydrogens are getting secreted, we're getting rid of them at the DCT, and we're reabsorbing bicarb, which will go into our extracellular fluids, which is a good thing, okay? We always want to have a bicarb reserve. The respiratory system, we will see a respiratory reflex try to get triggered, okay? Now, depending on why we're hypoventilating in the first place, will determine if we can change our respiratory rate. We may not be able to, but the body will try to trigger a respiratory reflex to increase respiratory rate so that we can get rid of CO2. If we can do that, then our CO2 levels will drop. At the DCT, our hydrogen ion levels will drop, and we will increase bicarb because we'll be reabsorbing it. That should then get our blood pH back to normal, and then we're back at homeostasis. If the respiratory reflex doesn't work and we can't increase respiratory rate, then we're essentially relying on the kidneys to do all the work. And that will work for short periods of time, but for long periods of time, that's not going to be, it's not going to do the job for long periods of time. All right, respiratory acidosis. If you have acute respiratory acidosis that's not corrected, that is a life-threatening condition, okay? That can wipe you out pretty quickly, okay? The major goal, if you do have somebody that is in respiratory acidosis, so let's say you've got a patient that has, that's in an overdose situation. They've taken a lot of opiates, maybe they've combined it with benzodiazepines, maybe some alcohol on top of it, and their breathing is super shallow at that point. If they are in that kind of acute respiratory acidosis, you have to do mechanical respiration for that person, okay? You've got to try to get that CO2 out quickly. So mechanical respiration is probably what you're gonna have to do here to keep them alive, okay? You can have people with chronic respiratory acidosis. The way this would work is their normal respiratory activity is compromised, but it's still functional. It's not completely normally functional, but it works enough, okay? So this might be somebody that maybe just consumed a lot of alcohol, but they're not in an overdose situation. So their breathing is depressed, but they're still breathing. This might be somebody that has emphysema, where their alveoli have been destroyed, but they still have enough alveoli to do gas exchange. But they're kind of in this chronic state where they just can't get rid of as much CO2 as they should be. They can get rid of enough, but not as much as they should. And that causes their pH to just sit in a slightly acidic kind of state. You can live with chronic respiratory acidosis. It's not the best for your body, but you can live in this kind of state. You're not going to be running marathons, but you could survive that. Okay, respiratory alkalosis is basically just the opposite. Okay, respiratory alkalosis, fairly uncommon. This is gonna be, the underlying issue is the person is hyperventilating. Person's hyperventilating could be for a lot of different reasons. Typically, you might see somebody hyperventilating because they're stressed, they're anxious, they're scared. Chronic physical pain can lead to a hyperventilated state. If you're in kind of chronic pain, that can cause you to hyperventilate. If you go up to high altitudes and you're not used to it, you won't be taking in enough oxygen and your body will cause you to breathe faster. You can then start hyperventilating in that situation. Sometimes people that are on mechanical respirators, it causes them to actually respirate too quickly and their CO2 levels will start to drop. So here, the underlying issue is the breathing is too fast. Breathing too fast means you're exhaling too much. That means your CO2 levels start to drop. As your CO2 levels start to drop, your blood pH starts to go up. So respiratory alkalosis, blood pH is too high. That would be greater than 7.45 because of or due to partial pressure of CO2 being too low, less than 40. 35, 40. 40. CO2 is too low, and the CO2 is too low because of hyperventilation. So again, the body will try to correct for this. We'll walk through that in a second, but we've said this before, you can do a quick, simple treatment. Give the person that's hyperventilating a bag to breathe in. They exhale their CO2 into that bag and then breathe it right back in, and that helps their CO2 levels to pop up, and that can correct this problem. Respiratory alkalosis usually isn't an acute respiratory situation because really people don't tend to hyperventilate for too long, right? Usually it's corrected relatively easily. Usually people can kind of calm themselves down a little bit, or again, you can breathe into a bag. Whereas hypoventilation, if you're overdosing, you're not gonna calmly increase your respiratory rate, right? This one usually is not gonna be a life-threatening condition, typically. So again, we walk through the same basic thing. So here we're at homeostasis. The individual starts hyperventilating, that causes partial pressure of CO2 to drop. It goes lower than 40. As the CO2 goes down, that causes less hydrogen ions in the blood. pH goes up. First thing that's going to happen are buffers are going to try to correct the problem temporarily. Buffering systems are going to act as weak acids, releasing hydrogen ions, except for the carbonic acid bicarbonate buffering system won't, because the problem is CO2 levels are too high, too low. So then we're gonna have at the kidneys, we're gonna see hydrogen ions again. Here it says generated. You can generate hydrogens. We didn't talk about it. We're gonna say hydrogens are reabsorbed, put back into the blood, while bicarb is getting secreted. A respiratory reflex will try to get triggered to slow the breathing down. If we can trigger a respiratory reflex and the breathing slows down, then CO2 levels start to rise. At the DCT, as we reabsorb hydrogen, we have more hydrogen in the blood, and as we secrete bicarb, we have less bicarb in the blood. That should get our pH back to normal, and we should be back at homeostasis. Okay, so now we're going to talk about metabolic acidosis and metabolic alkalosis. So let's start with metabolic acidosis. Up here. So metabolic acidosis. So when I think about metabolic acidosis, first of all, it's the second most common type of an acid-base disorder. First one being respiratory acidosis is the most common. Second one, metabolic acidosis. The two alkalotic states are pretty rare. Okay. Now, metabolic acidosis. We'll look at the three major causes of it, but where I first start with all this is I say metabolic acidosis is when your blood pH drops, so less than 7.35, because of any reason except for high CO2 levels, okay? High CO2 causes pH to drop, but that's respiratory acidosis. So if your pH becomes too low for any other reason, you're in the metabolic state, okay? Now, there's three key reasons why you typically are in metabolic acidosis. So let's go through those and make sure they make sense, okay? First of all, you're producing a lot of fixed organic acids. That should just kind of make sense. So the three most common reasons why you're in this, you're producing a lot of fixed organic acids. So again, things like lactic acid, things like ketones. Okay? Now, why would you produce a lot of these? So lactic acid would be if you're doing intense muscular activity. Okay? So not just a lot, but a lot of intense. When your body is forced, your muscle cells are forced to do anaerobic metabolism, right? They have to make ATP without oxygen, anaerobic metabolism. Ketones, okay? Ketones, we said before, you can have ketones produced due to uncontrolled diabetes mellitus, so that has to do with your glucose levels being too high, insulin's too low. Could also be due to starvation. Really low amount of carbohydrates being consumed. And when this happens, either in starvation or you do something like the Atkins diet or the keto diet, you're taking in really low amount of carbs or zero carbs. And what this is going to force is fats to be broken down. Fats will get broken down for ATP production. And when you start breaking down fats, ketones are a byproduct that you produce, and ketones are acidic. Okay, so this could happen. Okay. Second big reason why you might be in metabolic acidosis is if your kidneys aren't working properly. Okay. So if your kidneys can't eliminate hydrogens properly, that could throw you in metabolic acidosis. Typically at the DCT, you are subcreating hydrogens. And if your kidneys can't do that, plus there's some other things, this is talking about some other things in the kidney that we didn't talk about. So for right now, we'll just kind of lump it all together and say, if you can't get rid of hydrogens at the kidneys, that could be from secretion at the DCT or in other places that we didn't specifically talk about. So you could have kidney damage. You could start to see a buildup of hydrogen ions in your bloodstream. If you've got infection of your glomerulus, of your nephrons, that could cause this to happen. And then lastly, you can see metabolic acidosis if you have severe bicarb loss. Now, that doesn't happen very often, okay? So let's think about how would you end up with severe bicarb loss, and why would that lead to metabolic acidosis? Okay, so first of all, we said that you could have severe bicarb, we've already said this, you could have severe bicarb loss if you have chronic diarrhea, okay? So again, this might be somebody that has irritable bowel syndrome, something like that. So severe is the key word, and chronic is the other key word, chronic diarrhea. Okay. So here you're not absorbing enough bicarb at your GI tract. So now let's think about, why does that cause an acidotic state? If you don't have enough bicarb, okay, that brings us over to your major extracellular buffering system, this guy right here. If you don't have enough of this, and you should have a lot of that in your extracellular fluids, you should have a bicarbonate reserve extracellularly. And remember, we've said now a couple ways to make sure you've got a lot of bicarb extracellularly. One, you typically absorb plenty through the GI tract. Two, at the ECT, you typically are reabsorbing bicarb. And then three, what was the other thing that we said? You've got that chloride shift in your red blood cells. And there's other ways. So typically you've got plenty of bicarb, okay? Typically you have a lot of this, but let's say you don't. So now you've got very low amounts of bicarb. And this is your major extracellular buffering system. So if you have very little of this weak base, it means now that you can't buffer hydrogens that normally would be buffered, that normally would get buffered. So if you have so little bicarb, you can't buffer hydrogens because you don't have enough of the bicarb. So what are you left with? You have all of these hydrogens floating around that normally would get buffered by this, that would form carbonic acid, that would be eliminated through the respiratory system. And now they're building up because you have so little of this. And as these guys start to build up, your pH drops. So it has nothing to do with CO2 levels. It's because you have so little bicarb, you can't buffer enough of these like you normally do. They build up, your pH drops, metabolic acidosis. So now the question is, how do we try to fix this problem? Now, because we have a few different kind of reasons this could happen, when we think about how to fix it, we have to think about this one separately from these two, okay? So let's look at how we fix it. So what we've got here, this is metabolic acidosis. That's because of the first two things, having too many fixed organic acids or a buildup of hydrogens in our bodily fluids. That's this up here. The bottom part here is metabolic acidosis because we have too little bicarb. Okay, so let's start with the one up here. So up here, we're in homeostasis, and then one of two things happens. Either at the kidneys, we can't get rid of enough hydrogen ions, and or we're producing too much lactic acid, ketones, or some other fixed or organic acid. All those hydrogen ions causes our pH to drop. So we're going to have buffering systems. All of the buffering systems in these two situations will start acting as weak bases and try to absorb these hydrogen ions. That'll be a temporary fix. Then at the kidneys, if we can, we will try to secrete hydrogen and reabsorb bicarb. And as we are reabsorbing bicarb, again, that just helps with that buffering system over there to help buffer all those extra hydrogens that we have. a respiratory reflex will get triggered. It will try to make the individual breathe faster. As the person breathes faster, what you see at your pulmonary capillaries, so by increasing respiratory rate at the pulmonary capillaries, what we would see is more hydrogen and more bicarb coming together to form more carbonic acid, which will then form more CO2 and water that gets exhaled. As we increase respiratory rate, this reaction happens faster at the pulmonary capillaries, and we are getting rid of more hydrogen ions, okay? That reaction happens faster, we get rid of more. That should then correct the problem, okay? We'll see the partial pressure of CO2 drop. We should see through the kidneys and through the lungs less hydrogen, more bicarb. pH should come back to homeostatic range. Down here, we're gonna see exactly the same things happen with one difference. When we look at the buffering systems acting as weak bases, they all will do that except for the carbonic acid bicarbonate buffering system. Can't help to buffer the problem, because again, the problem is that we have too little of this. And if we have too little of this, then this can't act as a buffering system, because what we need is the weak base, and we have too little of that. So if we have too little of this, this can't work as a buffering system. Okay. Everything else will be the same though. Okay, so then this slide right here, I'm gonna come back to. This I will ask you for sure something about this on your test, maybe even a bonus question, right? I'm gonna come back to that in a second. And we're gonna talk about our last acid-base disorder. So let me get rid of this. This last one is metabolic alkalosis, and like respiratory alkalosis, it's very rare, okay? So you just don't see it very often. Alright, so metabolic alkalosis. I kind of think of it similarly to what we just did with metabolic acidosis. For metabolic alkalosis, I say this is when my pH is going to be too high for any reason except a drop in the partial pressure of CO2, because that would be respiratory alkalosis. Now, the main reason why you would see metabolic alkalosis, okay? The main reason you would see this, the main reason, is if you have way too much bicarbonate ion. Now, again, that doesn't happen very often because typically we have a bicarbonate reserve. We have a lot of bicarb, just typically. But here we're going to have an excessive amount of bicarb. Okay, so let's first say how that would happen and why that would cause pH to be too high. No, let's do it opposite. Let's first say why that would cause pH to be too high, and then we'll say why it might happen. So we come back to this buffering system. Okay, so for this buffering system, bicarbonate ions act as weak bases, and they buffer a certain amount of hydrogen, forming carbonic acid, which forms CO2 and water, and then that gets exhaled. Okay? Remember, this reaction is always happening, it goes in both directions, okay? And it's always occurring in your extracellular fluids. But if you now all of a sudden have way more bicarb than normal, so you've got way more of this than normal, then what's going to happen is hydrogen ions that shouldn't get buffered are going to get buffered. So now we're gonna end up, because we have so much of this, too much of this, we're gonna be buffering too many hydrogens that are in our solutions. You want a certain number of hydrogens in the solution because that determines your pH. And to be at 7.35 to 7.45, you need a certain number of just free hydrogens in that solution. But now, too many are getting buffered. And as too many get buffered, that means that we're going to then form carbonic acid. And we end up with too few in the extracellular fluid. And too few hydrogens causes pH to go up. That's how you get metabolic alkalosis from this. Now we want to say, how do you get too much bicarb? Okay, it's actually hard to do for long periods of time. I'll come back to this temporary thing in just a second. Serious alkalosis is going to occur where people have repeated bouts of vomiting. So this is not saying, oh, I've got a little stomach bug, okay? This is people that have bulimia, okay? Anorexics, well, bulimics really, more so. Or some other kind of condition. Maybe the person's doing chemotherapy and they're getting sick a lot, okay? This is chronic, repeated bouts of vomiting. So now we need to say, okay, why is that causing too much bicarb? Okay, why does that cause too much bicarb? And now we have to look at the stomach for a second, okay? So when you look at the stomach, in the stomach, you have some cells in your stomach called parietal cells. And parietal cells do a couple things. One, they make what's called intrinsic factor. An intrinsic factor is critical for absorption of B12 at the small intestine. So people that have damage to their parietal cells in the stomach, they don't make this intrinsic factor, don't make enough, and then they end up not being able to absorb enough B12 from their foods at the small intestine. And you need B12 for a lot of things, but in particular for hemoglobin synthesis. So people that have stomach issues where their parietal cells are damaged aren't making enough intrinsic factor, they can't absorb enough B12, and they end up not having enough hemoglobin in their red blood cells. And this leads to anemia. Okay? It's actually called pernicious anemia. Right? That's just a little side note. Okay? Okay. What we want to look at is the other thing that parietal cells make is HCl, hydrochloric acid. Okay, they make hydrochloric acid. Now, when you guys, see how much is on your worksheet. Some of this might be on your worksheet, I can't remember now off the top of my head. But HCl is required to set up a very acidic environment in the stomach that's necessary to digest proteins. Okay, in your stomach, you start digesting proteins. And HCl is a big player in that. Okay, now again, how is this all related to metabolic alkalosis? If we look at a parietal cell, okay, here's our parietal cell, and we say, how does this parietal cell make hydrochloric acid? Okay, this is how it does it. In this parietal cell, it's going to take CO2. Where did that CO2 come from, first of all? From where? From that cell. That cell made that CO2 as a byproduct from making what other thing? ATP, okay? So it's just a waste product, okay? CO2 is just a waste product of that cell. And that CO2 can diffuse out of that cell, and this parietal cell can also use that CO2. What this parietal cell also has is plenty of water, okay? There's always plenty of water in a cell. The other thing this parietal cell has is an enzyme. That enzyme, carbonic anhydrase. Just like a red blood cell has, okay? And what this parietal cell does with that CO2 it produced, water that it produced plus it has, and this enzyme that it has, is it forms carbonic acid. Now, you guys know carbonic acid is very unstable, so if we're producing CO2 in water, we have a lot of it, that then is gonna drive the reaction to the right, so that carbonic acid is gonna break down into hydrogen ion and bicarbonate ion. There's the hydrogen of the HCl that it makes, okay, right there, okay? So there's the hydrogen of the HCl that needs to make. Then it needs chloride, okay? And what we just learned when we talked about red blood cells is the bicarb gets pumped out into the extracellular fluid in exchange for chloride that will get pumped in. Okay, so there's the chloride. That's how a parietal cell makes hydrochloric acid, just like that, okay? It generates the hydrogen from this reaction that we've now seen multiple times being used in different ways. And when you produce bicarb through this reaction, it gets transported out and chloride gets brought in. Okay? So there's your HCl. Now back to, why do we care about this? We care about this because when you have chronic vomiting, your parietal cells are just cranking out HCl. They crank it out, okay? So as long as you're eating and you have food in your stomach, your parietal cells are making HCl, and that's how you can get this temporary elevated bicarb after you eat. It's called an alkaline tide. Okay, I'll come back to the vomiting in just a second. So whenever you're eating, as long as there's food in your stomach, your parietal cells are making HCl. So after you eat, what you'll see is a bunch of bicarb in your extracellular fluids. Okay, again, that's called an alkaline tide after you eat. All that bicarb causes your pH to pop up, but it's just for a very short period of time because again, it is corrected very quickly, okay? The bigger problem is repeated bouts of chronic vomiting. That's the problem. That is going to go on for longer periods of time. As long as somebody's vomiting, those parietal cells are producing hydrochloric acid. And as long as these cells keep cranking out hydrochloric acid, bicarb keeps rising in your extracellular fluid because of this right here. And as you get more and more bicarb being produced through this because of repeated bouts of vomiting, too many hydrogens get buffered in your extracellular fluids and your pH becomes too high. Now again, this is pretty rare. You don't see this too often, okay? But for bulimics, this is a big problem. Big problem. So how does the body try to correct it? We see this thing again, okay? So here we're in normal homeostatic range. We've got loss of hydrogen because too many bicarbs are overly buffering. That causes blood pH to become too high. We're in metabolic alkalosis. Buffering systems are going to try to work with weak acids and release hydrogen ions. All the buffering systems will try to do that, except this one cannot do it because the reason that we're in this state is because of bicarbs being too high. We'll see at the DCT, hydrogen ions will get reabsorbed, bicarbs will get secreted. Normally we reabsorb bicarbs, but now this will be good because of the DCT, we'll start getting rid of these so that hopefully our levels come back down. Through the respiratory tract, we will see a respiratory reflex try to kick in to decrease respiratory rate. As respiratory rate comes down, CO2 levels start to climb. As CO2 levels start to climb, that helps to get our pH to come back down. All right, questions on this stuff? I'm going to talk about this last slide and then I'm going to go back to this one and that's where we're gonna end for today. Okay. This slide right here, there's nothing on this slide that you need to worry about for your test, except I am gonna comment on that number right there in just a second. But if you find this interesting, and for those of you that think that you are going into kind of critical care in nursing or med school or nurse practitioner or PA, this stuff is gonna be really important for you. And so this basically walks you through how you could very quickly analyze someone's symptoms and their lab results to figure out which of these 4 acid-base disorders that they're dealing with, and then treat it accordingly. So, for example, if somebody comes in and they're showing signs of acidosis or alkalosis, first thing you do is just check their blood pH, right? Quick and easy thing to do, just check their blood pH. If it's acidic, then you know they're in, if it's below 7.35, they're in an acidotic state. If it's above 7.45, you know they're in an alkalotic state. Let's say they're in an acidotic state. So now you need to figure out, is it metabolic or is it respiratory or is it a combination? Next thing that you can do that's quick and easy, relatively, is draw blood gases, right? Check what their CO2 levels are. If their CO2 levels are too low, then they could be in, let's see, if their CO2 levels are too high, if their CO2 levels are too high, then it could be respiratory acidosis. Okay? And if it's not, if their CO2 levels are normal, then chances are that you're looking at a metabolic state. And then you can do the same thing with the alkalotic state. You check pH, you check your gas levels, and then you can kind of very quickly put it into the right category. The one thing that I keep noticing on here is it says for CO2 levels being too high, that's greater than 45. Here it says greater than 50, there it says greater than 45. And for CO2 levels being too low, it says less than 35. I'm gonna double check those numbers. You don't need to, we'll just say this. For your test, I'm not going to grill you about partial pressure of CO2 normal range because I'm wobbling all over that right now, okay? Know your pH numbers. CO2, don't worry about it, okay? I'll figure it out, I'll let you know, but I won't ask you on your test. Okay, so then let's come back to here and do this. Okay. So we want to say, why is it that your number 1 and number 2 acid, the most common acid-base disorders tend to happen together, okay? If you have respiratory acidosis, almost always you're gonna also have metabolic acidosis, okay? I'm gonna say, why is that? So, it does not have to be for this reason, but this reason is a good example to talk about. We're gonna talk about somebody that's drowning, okay? So again, you don't have to have somebody drowning to have both of these conditions linked. They typically are linked. So, but let's take somebody that's drowning, okay? You've got a drowning victim. And again, what we're talking about is why are respiratory acidosis and metabolic acidosis, why are they typically linked? And again, there's a good chance this might be a bonus question, okay? I won't promise, but there's a good chance. Somebody that's drowning, okay? They obviously are underwater. What's gonna start to happen to their CO2 levels? They're gonna rise, right? They're gonna rise. You're underwater, you're not breathing, right? You're not breathing in, you're not breathing out. You're underwater, you're drowning. So CO2 levels are gonna start to rise pretty quickly. And as your CO2 levels rise, your pH starts to drop. You are in respiratory acidosis right there. Okay. Now, typically, if your CO2 levels are rising, then usually you're gonna see your partial pressure of oxygen, typically doing what? If you're drowning, what's happening to your oxygen levels? They're decreasing, okay? So typically, if your CO2 is going up, it's because you're hypoventilating. And if you're hypoventilating, then typically your oxygen levels are going down, okay? It's not always true, but it's typically true. Now, let's also think about somebody that, well, let's walk through this first. So if your oxygen levels start to drop, then this is going to cause your cells to switch from aerobic metabolism, making ATP using oxygen, okay, to anaerobic metabolism, making ATP without using oxygen. If your oxygen levels are low, you don't have oxygen to do aerobic metabolism, so you're forced to do anaerobic. And a byproduct of anaerobic metabolism is lactic acid. Lactic acid. You don't get lactic acid with aerobic, okay? But if your oxygen levels are low enough, you can't do aerobic anymore. You have to do anaerobic. And when you do anaerobic, making ATP without oxygen, you always produce lactic acid. Lactic acid is an acid. Lactic acid is going to cause your pH to drop. So here your pH is dropping not because of CO2 levels, but because of lactic acid buildup. This is metabolic acidosis. So you tend to see these two linked because if your CO2 levels are rising and you're in respiratory acidosis, then you typically will see your oxygen levels drop. And if your oxygen levels drop, you're being forced to do anaerobic. And when you do anaerobic metabolism, you produce lactic acid and your pH drops, metabolic acidosis. Now, also for somebody that's drowning, are they calmly just sitting there waiting for someone to save them? No, they're flailing around, right? And when you do intense muscular activity, whether you have, that's not true, but when you do intense muscular activity, you do anaerobic metabolism because this makes ATP quick, okay? It doesn't make a lot, but it makes it fast. So the fact that this person's drowning, even if their oxygen levels weren't low, which they obviously are, the fact that they're flailing around, they would be switched over to anaerobic because of that anyway, okay? So again, this is what you've got. Now, to correct for this, okay? If somebody were drowning, the first thing you want to do is obviously yank them out of the water, right? Get them out of the water and get them respiring, okay? Either mechanical respiration, whatever, but they need to start breathing to get that CO2 out, okay? So to fix this problem, okay? For somebody that's drowning, you want to do, you want to get them breathing. Either on their own or with assistance. Assistance being you or a ventilator, something, okay? You or the ventilator. And this will get the CO2 levels to start to drop. Okay? Now, the other thing that you can do is you can, to kind of hurry this up, okay, hurry this up, you can give an IV. Okay, so this is going to speed things up here, speed up the pH correction, say that. You give them an IV that is isotonic to their cells so that they don't gain or lose a bunch of water from their cells. So this would be normal saline. But then we're going to add to it, we're going to add to that sodium bicarb. Now, let's think about why. if we add sodium bicarb to their IV, that sodium bicarb in their body break down into sodium and bicarb. And having extra bicarb, what will that do? That will act as a weak what? A weak base. Having that extra bicarb will act as a weak base and start buffering those extra hydrogen ions, right? That's causing the low pH, right? We're in an acidotic state. So this is just helping to speed things up, right? Their own buffering systems will help to buffer. This is just giving them like an extra shot of bicarb so that they can quickly buffer those hydrogen ions until we can get the hydrogen ions eliminated at the kidneys and or at the lungs. All right, questions on any of that stuff? All right, that is the lecture for today. I'm gonna go up to lab. I will see you up